Mark D. Faries, Ph.D., is an associate professor and graduate coordinator within the Department of Kinesiology and Health Science at Stephen F. Austin State University and an adjunct assistant professor within the College of Medicine at Texas A&M University. Dr. Faries directs the Lifestyle Medicine and Behavior Lab, and his research seeks to move beyond current perspectives to elucidate why and how people initiate and maintain health behaviors. He is also founder of FitnessPudding.com, a site dedicated to common health and fitness myths.
Just do it. Made famous by Nike. If we need to train a little bit harder, we need to stay after practice, we need to do a few extra repetitions, the simple prescription is just do it. It's made popular. However, if we applied it to exercise, we would say, I need to exercise more, so just do it. We might tell a patient who needs to eat healthier, just do it. Sleep better, just do it. Maintain and manage your stress, just do it. However, the prescription doesn't seem to be that simple. And actually, most people don't just do it. But I think we can learn a lot about being successful by looking at why people are unsuccessful. And what I mean is that from this perspective of lifestyle medicine, we know that eating a plant-based diet, maintaining a physical active lifestyle, maintaining a healthy weight, and not smoking can prevent upwards of 80% of all chronic disease. So we know that exists. Unfortunately, evidence suggests that about 3% of the population get all four of these extremely important lifestyle factors. So we know the medicine, but does it mean that Beverly, one of our patients, knows it, or does she enjoy it as much as we do? And what I mean is, we as practitioners might really enjoy physical activity. We might look forward to doing that, but it doesn't mean that Beverly does. We might enjoy eating a healthy diet and look forward to coming up with new recipes, and we really enjoy that, but Beverly does not. So just because we are passionate about lifestyle medicine and using physical activity and these other lifestyle factors to prevent, treat, and reverse disease, our patients might not buy into that. And a perspective is this. Let's say we had a medication that was 3 or 4 times the size. And if you've taken a pill that's extremely large, you know what I'm talking about. It's hard to look forward to taking a large pill. It's arduous. It's not fun. It's not exciting. Or if I had a pill bottle that took me 30 minutes a day, I had to twist the cap for 30 minutes just to get to the medicine, to be quote unquote taking my medicine. Now, this isn't an easy cap twisting. My arm burns. When am I going to find the time to make it happen? I don't look forward to it. So if our patients are perceiving this medicine, even though it might work, even though they might intend to do the behavior, we find that intention only predicts about 30 to 40% of the variation in physical activity and healthy eating behavior. Thus, it is now coined the intention behavior gap. The reason this gap occurs, from the perspective we're going to discuss today, is called self-regulation, or more specifically, there is a breakdown in self-regulation. So people intend to do it, but don't follow through. Because what they have to engage is this process of monitoring and changing their behavior when normalcy is interrupted. Normalcy being interrupted might look like this. If this is their normalcy, and they receive a diagnosis, they find they are hypertensive, perhaps they're overweight, or there's an obesity classification. We tell them, look, you got to fix this. You got to be more active. You got to maintain your stress, et cetera, et cetera. Thus, their normalcy is interrupted. The problem is, as soon as we interrupt it, they have to engage all of these tools and processes, these mental processes, to self-regulate so that eventually this is the new normalcy. But how do we get people there? It's not a simple prescription of just do it. That's why most people fail. But if we look at maybe some reasons that could moderate this relationship or this intention behavior gap, there are a lot more than what we're able to cover in this 1-hour webinar. However, these 5, I think, will give us a pretty neat perspective, not only from what we know, but maybe the future of how we can help connect intention to behavior in our patients. So number 1, the motivation. You might have heard several different definitions. What we're going to describe here is the general drive to change or act in a particular way. something you might not know is that there are different kinds. The first being the best, generally considered the best, is called intrinsic motivation. This means that we are doing a behavior because of the inherent enjoyment of that behavior. Next, you have extrinsic motivation, which means I'm not doing it necessarily because I enjoy it, but I'm doing it for a separate or extrinsic reward. Underneath extrinsic motivation, we have a type called other determined, which is in red, meaning that it's probably not the most popular, but I'm doing the behavior for reward because someone is making me do it, such as my doctor, my trainer, my counselor, my coach. Self-determined, on the other hand, I'm still doing it for the extrinsic or external reward, but I am doing it. Thus, it's self-determined. If we break that down a little further, we see that guilt or goal would be two options of self-determined. In other words, I'm doing it because I want to achieve a goal. I want to achieve something that's important or valued to me. Thus, it's in green. But in red, the guilt part can get us into trouble. I'm only doing this, and yes, I want to do it, but I do it out of guilt or shame. The final third category here is amotivation or no motivation at all. And what we'll see with the three different types is that if Beverly is communicating with us, I think the first step is we need to be able to listen to what they say and then attach it to what type of motivation they might have. So she might say, I have no desire to exercise, or the doctor comes in, the physician, the coach comes in and tells Beverly she needs to exercise. And she said, yeah, I'll start exercising, but only because you're making me do it. Versus, well, maybe she has no desire, or maybe in this case, I will do it just so I don't feel guilty. We might have the patient where she is really, really excited about exercise. I enjoy it, or I can do it so I can get healthier. I can maintain my weight. If we look at these different quotes that would come from the patient, Beverly in this case, and then we label them, what you notice is that depending on what she says, I now have a sense of what type of motivation she has. So coming from the doctor at the top right, it might be other determined. So she's doing it not because she wants to, but because someone is making her. A motivation, there's no motivation. So how do I handle that? Versus how do I handle if she's doing it out of guilt or shame or avoidance of guilt or shame? Versus what if she does do it out of intrinsic motivation or self-determination? How do I work with those different patients? And this is what we see. We're working with a lot of patients that either start out with no motivation or some form of other determined motivation because there's some outside entity making me do this. Well, how do we get those folks to this more inherent enjoyment, this intrinsic type of motivation? There's a few things you need to know. First, there's sources of intrinsic motivation. The three we highlight here are to know, to accomplish, and to experience stimulation. To know is learning for its own sake. We have an innate drive to learn things and to just know. We also have an innate drive to accomplish, meeting optimal challenges. To experience stimulation, for example, is the third. This is doing things because we inherently enjoy the fun and pleasure. So take reading a good book, inherently enjoyable. We don't have to do scheduling or plans or keep a log or have an accountability partner or any of that. If it's a book that I enjoy to read, it's intrinsically motivating, I just do it. Of course, being from Texas, the History Channel has this Texas Rising show. I inherently enjoy watching the History Channel, or if you've seen how it's made and you sit in the hotel room or at the house and watch how they make a light bulb or a soda can. We do that just because the inherent knowledge that we enjoy, it's intrinsically motivating. Again, we don't have to regulate our behavior. We do it because we like it. Apps are extremely addictive. There's so many options, but think about this. You can learn, you can meet optimal challenges, and it can be fun and pleasurable. So potentially the perfect app is tapping into all three forms of intrinsic motivation. Thus, it's extremely hard to put them down, and it's something that can become addictive. Well, if apps are making all this money, if these video games are making all this money, tapping into the three sources of intrinsic motivation, we might consider how can we tap into those from an exercise, healthy eating standpoint. The problem, though, is when you start looking at behaviors like exercise and healthy eating. So in this case, let's say we asked a patient, and they were relaying this information. And this item is actually from the intrinsic motivation inventory. Any behavior could be plugged in the blank. I try or would try to blank on a regular basis. Two of the responses on the survey are because I enjoy blank, whatever the behavior is, or two, because it's fun. So let's say we asked a patient, lose weight, especially if they are coming to see you for weight loss. I would try to lose weight on a regular basis because I enjoy losing weight. Well, they tend to say, yeah, I enjoy losing weight. That's why I'm here, because it's fun to lose weight, sure. I love to see the scale drop or the body fat percentage go down. But if we ask them, okay, what about eating healthy or exercising? Well, I don't enjoy that as much. I enjoy the outcome, right? I enjoy the weight loss, the fat loss. But the process, now I don't enjoy that as much. Exercise, not as fun. If we even dig down a bit more, specific behaviors you have to do day and day, moment to moment. Passing on the dessert, yeah, that's not fun at all, especially when I want it. Going to the gym, no, I don't enjoy that. I'd rather be home sitting on the couch. So we see that people are intrinsically motivated, inherently enjoy the outcomes of the effort, but may not necessarily enjoy inherently the process and the behaviors it takes to get to that outcome, thus the intention behavior gap. Jill may hate exercise. Lisa loves it. Lisa convinces her, look, you need to go lift weights. It's good for your bones. It's good for your functionality, activities, daily living. I enjoy it so much. I've improved, et cetera, et cetera. But that does not mean that Jill's going to enjoy it. So Jill might be doing it because Lisa's making her. Other determined, where Lisa's doing it because she inherently enjoys it. Those two patients I would handle differently. So this is a picture, a true picture of one of my walks to work every day, actually to campus. And I love it. I get to walk through this and decompress, and I get 30 minutes to work and 30 minutes back. So this is inherently enjoyable for me. And some of you might agree, yeah, if I could walk in that, I would just do it just because I enjoy it. Nobody would have to make me. I don't even need an outcome. I don't need to improve my blood pressure from this walk. I don't need to lose weight. I'm just going to do it because I enjoy it. However, what if it's raining? What if it's cold? Well, now I don't inherently enjoy it. So intrinsic motivation, especially of the behaviors, can be fleeting. In other words, there has to be certain parameters for me to inherently enjoy it. So what are my options then? What are my options if it is raining, if it's cold? And if you ask patients this, think about it yourself. What would you do? Most would just not do it at all. But could there be some other potential opportunities? Could they pop in a video at the house? Could they go to the gym? Could they maybe take the stairs, jump on the elliptical in the basement, walk on their treadmill, maybe go to the mall and walk with some friends? We have to have options. Options are very good, especially from the physical activity standpoint, because as soon as you don't have one option, then what do you do? 4 or more options have been shown to greatly enhance the odds that someone is going to reach physical activity guidelines, a statistically significant improvement. So if you want to improve the odds of people connecting the intention to behavior gap, you clearly want to choose options that are intrinsically motivating. But you also want to have options because the inherent motivations associated with these things that we like have certain parameters, and those can be fleeting, so we have to make do when those things don't match up. All right, so what if somebody's A, motivated, and other determined, but you know what? I'm never going to get you to the point to where you love exercise, at least right now. Or I'm not going to get you to the point here in the short term to where you are going to love healthy eating, you're going to love passing on the dessert. But could I get you to the point to where you're doing it because you want to do it? At least you're not A, motivated, or you're doing it because you're not doing it because someone's making you. But are you doing it because you want to do it? Yes, you're doing it for an outcome, but you want to do it. And if you look at the data, most healthy eaters and most exercisers, people that maintain a physically active lifestyle, are actually more self-determined. In other words, why are they doing it? I'm doing it for my health. I'm doing it for my physical functioning. I'm doing it for my body image. Those are extrinsic external rewards to the behavior, but nobody's making me do it. I want to do it. And so that's how a lot of people can actually intend and follow through with their intention because they might not inherently enjoy it intrinsically, but they do it because they want to. And what happens is if we want to build this sort of self-determined motivation in our patients, we tap into these 3 innate needs. Now, of course, we would still tap into the three sources of intrinsic motivation, but we want to make sure that people feel a sense of autonomy, that they are the origin of their own actions. This would tie into the options that we just saw. They are self-determined. We'd want to set it up to where they feel competent. They demonstrate and exert control over their environment, and they feel that they are in control. Or relatedness, and you've heard this many, many times before, I'm sure, the need to be in caring relationships and find your place in social order. If you have to exist in an environment where you have no autonomy, you have no competence, or you don't feel competent, or you don't feel a sense of relatedness with those around you, it's going to be extremely hard to be motivated to do that. So how can we set up the environment to tap into these three needs? Well, autonomy from an exercise standpoint, for example, we want to set it up to where it's challenging yet attainable. It can't be too hard, because if it's too hard, then I'm not going to feel very competent. But if it's too easy, I'm not going to build the mastery experience I need to get more confident and to move forward with that behavior. And it would be the same thing with healthy eating. If we're doing diet planning, is it extremely complicated and I got to watch all these calories, I got to watch all these nutrients, and it's just way too much at first, so it's not attainable? Or can I establish some sort of dietary plan where it's challenging but still attainable? That's going to build more mastery experience, more self-efficacy, and tap into the competence that we're really intrigued with. Now, relatedness, again, we know meaningful relationships. We can set up group classes. We can set up sort of group visits in the medical clinical setting. We can do a lot of things to make sure people are connected with each other. Sometimes if it's a one-on-one situation, single mom raising 3 kids by herself, working 2 jobs, how in the world do I be successful with my behavior change? Well, hey, guess what? I know so-and-so, she's also a single mom. She has 3 kids, she works 2 jobs, but she's made it happen. So I'm going to connect you two. So that vicarious experience and learning through others can be extremely important, building this sense of relatedness. For some people, you as the practitioner, you're the only source of relatedness. Thus, you have to take on that role because they're not getting it from friends, family, or their peers. So you might be that only source. Enjoyable. So when we pick things, again, we already learned that behaviors that are intrinsically motivating are enjoyable. We do them because we inherently enjoy. Physical activity, there are activities that actually meet minimum moderate intensity levels. And if you look at the physical activity compendium from the American College of Sports Medicine, it lists a lot of different activities and the MET or metabolic equivalent numbers for each one of those activities. Moderate intensity is anywhere from 3 to 6. So you can go down that list and you could look and say, oh, there's a 3 to 6. I like that. Gardening, for example. Gardening is a 3 MET activity. Well, I love to garden. Well, great, get 150 minutes of that per week. Or if there's other behaviors such as walking or cycling, but there are behaviors such as maybe fishing from the bank. That can be moderate intensity. Well, I love fishing. Well, great. You get to go fish, or you get to do this or do that. So the goal is to steer people toward activities, not necessarily exercise, right? But toward physical activities that are enjoyable. Thus, they will feel more autonomous and in control to make those happen. From a dietary standpoint, we would see it in the same way. We would help people choose healthy options that they enjoy. No use to force people to eat the foods they don't like, because the odds that they're going to eat them are going to drop drastically. Let's focus on the foods that are healthy, that can get them to their goal, but they enjoy. Over time, we can try to build upon the activities that people enjoy. We can try to build upon the foods that people enjoy as well. Now, the trigger. This is actually my particular area of interest at this time. I'm interested in how people change, but more specifically, why people change. We can tell people until we're blue in the face, you need to change so that you can get healthy, or you need to change to this or that, but they don't. I'm interested in why one person can change when they are found to be discrepant in one type of, let's say they are found to be hypertensive or diabetic. They change everything, another person finds out they're diabetic and do nothing. So how can these discrepancies in some turn into a trigger or a spark for change, but in other people, it does not? I think it's an important question as we move forward, and it makes us tap into who people are and how they view themselves. Everybody, all of us that are listening now, have an actual self, a view of ourselves, who we think we are, our identity, our self-concept. We also hold a perception of who is the ideal self. Who do I want to be? Who is that ideal person, the ideal makeup I strive to be. There's a third person called the ought self. So this is the person that I ought to be, the person I should be because of some outside pressure. So the medical trigger of particular interest here, what happens is the medical provider creates a discrepancy. They give a standard of either an ideal, you need to be this weight, or an ought, you should be this weight because I'm telling you you should be. It might not be your ideal, but I'm telling you that you should. That discrepancy is created between either the ideal or the ought self and the actual self. Thus, the person should be motivated to change, and we'll see some issues with that in a moment. The first thing it does is it does create awareness of that discrepancy from either their actual self and or their ideal self. But recognition of guidelines, and this is an error that a lot of us make, recognition of particular guidelines like health guidelines, dietary guidelines, physical activity guidelines, they do not signify understanding. So just because I've told a patient what to do doesn't mean they understand that. Also, it doesn't matter how credible you are, because the perceived credibility of the source, like the medical provider, also does not guarantee use of the guidelines. It doesn't guarantee that intention is going to be connected to behavior. So how do we do that? Well, we first realize that self-concept, the actual self, is somebody's identity. Our identity is made up of things that we value. So what does your patient value? Have you asked them, what do you value? What's important to you? If we do, we start seeing what could make up and what could drive the decisions that they make. We actually can understand the way people think and act when we know what's important to them. And this is how it works. At the top of this hierarchy I'm going to show you is self-concept, or the view of self. And we all have this. The next level are things like our competence in the professional world, or our competence in our social spheres or social world. In the middle there, you see physical self-concept, which we deal with quite a bit. There are actually sub-levels under all of these. And there are other domains besides professional, physical, and social that we would have, that we find important, that we want to be competent. When we are competent, it improves the view of ourselves. But under the physical self-concept, you see 4 subdomains: physical condition, health condition, attractive body, and physical strength. And these 4 are commonly looked at. In our lab, what we've actually seen is that the attractive body is extremely important for our patients coming in to seek weight loss. And that's a very common reason why they want to do it. And it might not be due to their physical condition, that it's difficult to take the stairs, or their physical strength, or even their health risk. There are some, but we see the majority of our patients pursue the attractive body. Thus, we might do a body composition scan and tell them, this is a percentage of your body is fat, this percentage is muscle, this is your bone density. When we do that, what happens is we actually threaten that subdomain, which in turn threatens their physical self-concept, which in turn can threaten their overall view of self. If I perceive this as a threat to me, I'm going to have to deal with it in some way, and I'm going to show you why that's important in a moment. Now, this is a very common path. But the threat of an unattractive body, for example, might also impact someone's social competence. It might also impact their professional competence. And this would be the same thing if if their health risk was the threat, would subsequently impact their physical self-concept and then their overall view of self. So knowing that these subdomains can be threatened are important, because in practice, that's really what we're doing. We're diagnosing and we're telling people where they don't match up to a standard. Thus, we create a discrepancy. That discrepancy, does it act as a threat or does it not? If it does act as a threat, then we see the person change. But we really can't understand where the person's coming from. We can't really understand their behavior without consideration to whatever their standard is. For example, is their standard a blood pressure? Is it a model? Or is it an old picture from their wedding? 50 years ago, 12 years ago, 10 years ago. Are these realistic? Yes or no? Are they the proper standard to be held? Some are more objective, like a blood pressure. Some are definitely more subjective, like a view of self. And do I look attractive? Yes or no? And so these things, even though they might be driving someone, they might be driving them to do unhealthy behaviors. But we have to understand that. Instead of ridiculing or judging patients because they're doing some fad diet or a cleanse or something that doesn't match up to health, But if their standard is to look like a model or to get back to a weight they were 20 years ago, then you know what? That kind of makes sense. That makes sense why they do that. Yeah, I don't agree, but it does make sense because we can't understand people's behavior until we understand the consideration of their standard. When we counsel, when we work with patients, there are these moments that arise, and we've all had experience with this, where, okay, this is the moment, this is a teachable moment. I'm going to take this moment and we're going to really chime in, we're going to get to the point, and we're going to create change. These are very important moments that occur. We try to come up and we research ways to create these, but it's difficult to create. We do know when teachable moments occur, which lead to triggering events and can lead to lasting change. You see in blue that there is typically a redefinition of self-concept. In other words, there is a threat, as we just saw with the hierarchy. Or people start thinking, okay, this is not matching up to who I am. We always consider where people come from and their standard, but we also look at what they value. Are there personal risks? Or is that value, what they value, being threatened? Typically, this is all also associated with an emotional response, which is an extremely third important part of what we're talking about today. So let's look at this response. Typically, in general, when a person has a discrepancy, they found out they're hypertensive or they're diabetic, or in this case, they find out that they were successful. So they step on the scale, they had a goal to lose 5 pounds, and sure enough, they lost 5 pounds. So in general, they would experience positive feelings, and their motivation to do whatever they were doing will continue. Whether the behavior was right or wrong, they will have motivation to continue that behavior because, again, it gave them a successful comparison. However, unsuccessful comparisons lead to negative feelings. And what's interesting is that can lead to, theoretically, changing behavior, giving up, or trying harder. So it's not that all negative feelings are bad per se, because sometimes we do need to be frustrated and change because what we're doing, we need to do an extra day of exercise, or we need to clamp down on our diet a little bit better. Clearly, we don't want people to give up unless they're doing some unhealthy behavior and try harder, and that can happen, and that can be an important behavioral factor to keep people going after their goal. So let's look at the negative feelings. Specifically, we're going to look at how maybe emotions tie into this world of effort or motivation. On the bottom axis, you have the standard. So the black line going vertically in the middle of the picture here. If somebody meets the standard that's been set before them, then you can see and track up to the blue line. You notice their level of effort is quite high. However, if you move to the left, as people get further and further below the standard, so let's say the standard was to lose 10 pounds, they lost 9, 8, 7, 6, maybe they even gained weight. At some point where you see the red vertical line, effort drops off to extremely low to 0 levels. So if we get too far away and our comparison gets too unsuccessful, then the subsequent effort will be low. Well, to simplify this, we can actually put emotions so that when we hear people discuss things, we can say, okay, now I know where that's going to probably match up to your level of effort. So think about a patient that is depressed or sad. Well, their level of effort is probably going to be lower. If they're frustrated, eager, happy, then maybe their effort's going to be high. If they're blissful and too happy, then they act as what we call coasting. Their effort actually starts declining because they did so well. If we hear, again, how the patient discusses things, well, how does that make you feel? We're not only asking our patients, what do they value? What's important? But ask them, well, how does that diagnosis make you feel? And let's say Beverly says it makes me angry, makes me sad and very disappointed, or, well, I'm pretty frustrated right now. Well, based on the theory that we just learned, 2 of those can lead potentially to higher effort. Thus, my job as the practitioner, the medical provider, is to make sure that Beverly chooses the right behavior to supplement her motivation and her higher effort. But if Beverly is sad and very disappointed, depressed, despondent, well, now she's going to probably have lower effort, and I'm going to have to accommodate that emotion before I let her leave my presence, before she leaves my office. I need to get her at least to the point of frustration and understanding where she is. I need to counsel her in a way, because if she leaves sad and disappointed, then the worry is that she's going to have low or no effort. She might give up, thus not connect intention to behavior. And actually those can lead to reproach. Those sort of feelings can lead to healthcare avoidance. And I would be remiss if I did not talk about the emotional responses associated with the behavior. So I mentioned to you earlier on that a lot of us watching this webinar, most of us, if not all of us, probably enjoy these behaviors. We're very passionate about physical activity, healthy eating, etc. But we already established that our patients might not. One reason is that in this case, healthy eating, the behavior itself can lead to negative feelings. For instance, some questions we might ask our patients. How good does the healthy option taste? Well, it might not taste near as good as the unhealthy option, and that's, again, my standard. That's what I'm comparing things to. We might ask, passing up fast food when it's wanted, how does that make you feel? Well, no, it's crummy. I hate passing up fast food. I'd rather stop after work, get fast food, eat it. I love it. I enjoy it. Instead of having to drive all the way home, find something to make, and try to get that done. It's just going to take time, and they start rationalizing. Now, we don't have to enjoy it to do it, but we have to understand that those behaviors can lead to negative feelings. I had a patient once that she had a very unhealthy lunch, and that was probably somewhere between 12 and 1,500 of her calories per day. And so we had a discussion of other options, and she started talking about how she loved salad, and she had all these different salad recipes. And I said, that's it. This is the teachable moment. I want you to bring a salad every day to work. She said, I can't. I said, okay, well, why? I thought you loved them. Oh, I do love them, but I can't bring a salad. She said, I can't bring a salad to work because if I do, people are going to know that I'm on a diet. Well, that makes sense now why you don't want to bring a salad. So the process is much deeper than just do it, just bring a salad to work. Well, no, I don't want people to know I'm on a diet. I'm insecure with some of these things. I have some social physique anxieties. I have this and this and this. Those things stemming from the emotional response can give me a lot of information how to work with my patient. If we don't take care of these things, they can result in reproach, and then Beverly might say, I will never diet again. But healthy eating is not alone. Exercise can also be a behavior, and is commonly a behavior that can lead to negative feelings. And so we have to make sure that our patients, when they do initially start exercise, that they don't have such a negative response. The problem is that when we exercise, or in this case streak, there are physiological responses that occur. For instance, increased heart rate, increased ventilation, there's damage of the muscle, fatigue, sweat, the receptors inside of the muscle are tickling the nerves and afferently sending signals back to the brain. And the brain has to interpret, is this good or bad? And some of you might can relate to this, that when you go exercise and the feeling of exercise just doesn't feel real positive. But the research shows that some people can exercise. You take someone and that's not that active, you put them on a treadmill at 70% of their max heart rate or their VO2 max. They exercise, their heart rate goes up, they ventilate more, the muscle fatigues, they start to sweat, their heart gets faster and faster and faster. You ask them how that workout went, and they might say, that was terrible. It was a terrible experience. Are you going to come do that again? No, it was terrible. But if you take someone that's more fit, more confident in their abilities, you put them at the same relative intensity, 70% of their heart rate, 70% of their max VO2, their heart rate also increases. They ventilate, they breathe harder, the muscle fatigues, they sweat. But if you ask them how the workout was, they might say, wow, that was a good workout. The same physiological stimulus was being interpreted completely two different ways, and that was moderated by their fitness level, by their experience, by their self-efficacy or confidence in their abilities. So if we're dealing with patients that don't have that confidence, we need to make sure that that first experience with physical activity is a positive one. We can measure this. This great scale by Ed Macaulay, well-being, fatigue, and distress are 3 factors of the subjective exercise experience scale. Ask your patients how they feel, and you can look up this measure. Do they feel strong, great, positive, terrific? Well, that would be more about their overall well-being. Exhausted, fatigued, tired, drained, that would be more of a fatigue measure, which happens with exercise. But you notice the one on the right here, distress, crummy, awful, miserable, discouraged. Is that how we want our patients to feel early on? There is a lot of popular exercise now that's high intensity interval training. There are other programs that are designed and actually advertise that wimps are not allowed and that you're going to come and you're going to train hard. Well, what we're seeing is that might not be the best option for early exercisers, because the way we interpret these behaviors will dictate whether we want to stick with them. And just to reiterate this, these really great, clever studies have been done. They bring inactive people in, and they use this scale at the bottom called the feeling scale, from -5, very bad, to 0, neutral, to +5, very good. The studies that they measure, they're measuring this, how people feel during their first exercise bout, okay, a little 30-minute, 15-minute, whatever the study shows. What they found is, Dr. Williams found that in 12 months later, so in other words, how the person felt in their first exercise or physical activity bout, and this was a brisk walk, predicted their physical activity in minutes per week 12 months later, 1 year later. So in other words, every increase to the right, every improvement in how they felt on that first exercise bout predicted an average of plus 41 minutes per week, every increase in this feeling scale. It's profound, and this is a year later. The review by Rhodes and Cates, 2015, summarizes the research on this and comes to the conclusion that yes, how you respond to that first exercise bout early on with exercise or physical activity will dictate years down the road, potentially, how you interpret and how active you actually are. Now, a lot of our diagnostic processes are creating discrepancies. The one that we use in our lab currently is weight or body composition. There is this current knowledge that maybe I should avoid this stuff because of the way it makes me feel. Well, if we do a DEXA scan, for example, these 3 different women are actual DEXA scans. They've had their body composition scan. I've taken out the lungs just because they look weird typically to our patients. And so we look at this. How would these 3 people respond? And would they respond differently to seeing their image? Does it make them feel better? Does it make them feel worse? Is the assumption that if I show them this, they're going to be motivated to change? Or are they potentially going to be motivated not to change? Or are they going to be motivated to avoid and never see me again? The emotion will tell us a lot about this. We did a study a while back where we did the DEXA scan, and we gave participants body fat percentage, and this was men and women. You notice the women and men that found out they were normal body fat percentage had a decrease in positive feelings once they found out what their fat level was. Something about hearing about their fat and going through the whole process decreased their positive feelings significantly. The high body fat group, the ones that found they were over the limit, also had a decrease, and it was a little bit larger. What was really interesting was the negative feelings. The normal body fat percentage didn't necessarily have a change in their negative feelings, but look at this. The high body fat percentage participants had a significant increase in their negative feelings. Why is that important? Well, we just found negative feelings can lead to our patients to change, try harder, or give up. So now when somebody feels negative, I got to figure out what are they going to do with those negative feelings. We also found that people will respond in a couple of different motivational ways, and we use EEG to measure subconscious brain activity when people find out their weight, or specifically this study was their body fat percentage. If the right frontal lobe is more active than the left side, they are giving a label of avoidance, so like watching a scary movie. The left frontal lobe, if it is more active than the right frontal lobe, we call those approach. So this would be something like watching a happy movie. And previous research has established that there are frontal asymmetries in this way. Right frontal lobe is more active than the left, thus avoidance. The left frontal lobe is more active than the right, thus approach. So we established this process with women finding out their body composition and created an asymmetry index. In short, almost 70% of the participants, their left frontal lobe was more active than their right. Thus, they became more approach over time, from before finding out their body fat percentage to after. Nearly 30 or so percent of our population were avoidant, so they became more right frontal lobe heavy or more avoidant. And we looked at a few different things. First thing we looked at was, what is the change in comfort food consumption the week following this test? We find, ironically, that comfort food consumption is a common behavioral choice in women following body composition analysis or their weight analysis. And so comfort food, again, it's against their goal, but they're still doing it because why? The thought is that it can raise positive feeling states. With the approach group, there was no change in this consumption. However, with the avoidant group, there was a 4-time increase in comfort food consumption the week following. So we always think, yeah, this is what they're doing because they're having a negative emotional response. And so they're doing it in response to the negative emotions. Well, this is what we found. The emotion were both negative in both groups, and it was the same. But the top group did not have a change in comfort food or coping mechanisms, but the bottom group did. So it's not just feeling negative. It's this negative feeling in combination with an avoidant type of mentality, an avoidant motivation. So anything that we do that would enhance avoidance is probably not going to bode well for connecting intention to behavior. And that's why we learn to frame our messages differently to patients. And you can look at this research, it's pretty profound in that positive, more gain-framed messages, if you exercise regularly, you will be healthy, versus avoidant or loss framed. If you don't exercise regularly, you will not be healthy. In general, the positive gain frame messages tend to do better, and that's something that we should probably focus on, not only from a positive aspect, but as we just saw, from more of an approach, a goal-driven mentality versus an avoidant, non-reward mentality. All of this discussion about emotion and behavioral choices to deal with the emotion, we have to start thinking about behavior as coping. Yes, even healthy behaviors as coping, because we've already established that people aren't necessarily doing this because they enjoy it. They might, and we probably should be setting up environments where they do. But a lot of our patients are choosing behaviors only because they're trying to deal with the emotions and the mood that they feel. We found this sort of relationship with a recent study with women with any sort of weight or fat related trigger. We found that some women responded with this positive reframing where they would take the situation about their weight and make it seem more positive. Then there was another group of women that would sort of accept their weight, that would disengage. There's nothing I can do about it. Very hopeless, very avoidant. Subsequently, relationships told us that those who positively reframed actually started monitoring their weight more. They started monitoring their food intake. They started planning out their diet, their physical activity. Thence we see the green arrow here. The acceptance disengaged group, the red arrow, says they did less of that, or at least there was a negative or no relationship to those behaviors. Comfort foods, as we just saw, those who accept and disengage tend to do more comfort food. They tend to also say that they camouflage their body more. In and of itself, camouflaging the body specifically with clothes is not necessarily good or bad. But as we'll see, it didn't bode well for the folks trying to lose weight, specifically with healthy behavior. Those who did monitor and plan tended to exercise more. They tended to have higher ratings on healthy eating and healthy food consumption. But they also had an increase or higher level of suppressing their appetite or using supplements. And we don't know for sure why this is, but I think at this point it's probably something related to control or self-efficacy. I have patients that they're doing everything right. They're monitoring, they're paying attention, they're aware, they're paying attention on purpose. But they're choosing the cleanse. They're choosing the supplement that they probably shouldn't be. They're suppressing their appetite because that's what they know. That's what they've been successful with in the past. And so now I have to gear them and build their confidence, their competence, as we saw earlier, in exercise and healthy eating. Those who chose to deal with it with comfort food did less exercise and healthy eating, as did the camouflage, but more suppressing appetite and supplement. So now, working from left to right, after the diagnosis, after the trigger, we're not only focusing on the emotional response, but how do they deal? How do they cope with that emotional response? Is it through positive reframing or is it disengage? I need to know that as a practitioner so that the cascade of events that follow are going to steer people in the right direction. Specifically, our hope is to adopt these healthy lifestyle factors that can prevent, treat, and reverse our leading causes of death. Okay, but do people have the capacity? Remember I said that when we interrupt normalcy, when we interrupt somebody's current day-to-day activity, unhealthy diet, sedentary lifestyle, stress life, do they have the capacity to move forward? We called that self-regulatory abilities earlier. Now I'm going to focus on the specific capacity of the brain. And actually, self-regulation is made up of what are called executive functions. Now, executive function happens in the frontal lobe, which we saw earlier with the approach avoidance. Goal-directed behavior, concentration, emotional control, problem solving, delayed gratification, All of these are very important functions that we need to be successful, not only with healthy eating diet and perhaps physical activity, but other behaviors in life. So what if somebody doesn't have the capacity to make that happen? So now research is really focusing in on these smaller functions, and can they potentially predict and improve people's adoption and connect the intention behavior gap? We've already shown that executive function does separate obese individuals versus normal weight. In other words, obese individuals tend to have more executive dysfunction. Cognitive decline with older adults is probably the most common area that we've heard. There are gender differences, and there's this really cool line of research that from the treatment that cancer survivors get, there can be a decrease in executive function. Thus, they don't have the capacity to continue with physical activity, to increase physical activity, to eat healthy, and it makes it more difficult for them. So research now has found that. So now maybe we can implement strategies to improve the executive capacity so that they can follow through with the prescriptions that we've given them. I'm going to do a little test here. You can try this out loud, especially if you're by yourself. One of the executive functions that we look at is called attention inhibition. It is measured very commonly by the famous Stroop word task, color word task. And so, for example, you have to pay attention to the word, but then you have to inhibit a normal response because you're asked to give the actual font color of the word. So I'll give you this quick example. What would you say here? Well, you would say green because that's the font color. If you said yellow, then you got an error because you paid attention, but not enough. You did not inhibit the response. We want to read the words. That's how we learn it. So that's the dominant response. Can we pay attention and inhibit that? This characteristic we'll find is extremely important. But before I show you that, I'm going to give you a little test. So again, if you're by yourself, what I want you to do on the next words that come up, I want you to label or say out loud the color of the word as they come. You ready? Go. How did you do? I think I heard a green on the last one there, which is common. I want to say blue, but I'm supposed to say green. Thus, I failed at that little task. Well, as fun as that is, we find that, for instance, in fruit and vegetable intake, this study found and used a little different test, but still measured attention inhibition. They had two groups of people. They brought them in, and they said, look, this is your fruit and vegetable intake now. Do you intend to get more fruit and vegetable intake over the next week? And they gave them a goal. Well, at the bottom, you see there was a group of people that had weak intention. So they didn't have no intention, but they had weak intention to get more fruits and vegetables the following week. On the right, you see strong intention. So there's a group of people that, yeah, I have strong intention. But at the top in the blue bar ends up telling us that those were people who had strong attention inhibition. So example, in the Stroop task that we just did, they would have scored very highly. They would have done really well. The red bar, the weak executive function, they would not have done well. So what we see with weak intention, you notice there wasn't much change in fruit and vegetable intake. Well, because they had weak intention. And it didn't seem to matter whether they had strong or weak executive function, particularly ability to attend and inhibit responses. But check this out. The strong intention people, it was only those that had strong executive function that did well on the task that actually did change their fruit and vegetable intake. So why is this important for us? We started out this conversation talking about the intention behavior gap. So these two groups to the right, they both had intention to get more fruits and vegetables, but who was the only group to follow through? The strong executive function. So if you have a patient, potentially, right, that has strong intention but does not have the attention inhibition capacity, even though they intend to do it, they might not follow through. This was a great one on breakfast consumption, but looked at another popular executive function called planning problem solving. Same setup, weak intention versus strong intention. And then the blue, there was strong planning problem solving abilities versus weak problem solving abilities. In this scenario, strong intention, if you intended to do it, they did it. It didn't matter if they were good or bad at problem solving because intention overrode that. But this is what was neat. When there was weak intention, so this is somebody saying, again, not no intention, but yeah, I've tried to, I'm not really intending that much. The ones that could actually plan and problem solve, even though they had weak intention, connected the intention behavior gap. Super interesting. So now we got a participant or a patient that might not have strong intention, but they have the executive capacity to follow through with it anyway. And this would clearly dictate the prescription we give. Do we give in a complicated type of food log or a prescription, or do we give an easier prescription, challenging yet attainable? Notice this is going back to our competence talk earlier. We have a study under review now where we did men and women, and we looked at, we brought them into the lab and they had measured their steps per day the previous week. They get into the lab and we give them a goal number of steps per week that is 50% more than what they were getting. We measured several executive functions, and we wanted to see in our participants which executive functions related to change in steps in our participants. Well, we found, for example, those who got less than 7,500 steps per day, which is our goal for health, planning and problem solving actually worked best for them, or it was the highest correlate to change in steps. Men, it was working memory. Well, with women, planning problem solving worked a bit better. With our normal weight folks, planning problem solving worked well. Attention inhibition was related to increase in steps and reaching the goal of 50% more steps the following week. But in the overweight, it was working memory. So I picture this as sort of like a sound board, and that everybody has this executive profile, so to speak. I'm low here, I'm good here. But think about the person, like we saw earlier, that is a woman who's overweight. Well, maybe we can target particular executive functions to improve, or maybe if I know she is delayed in, let's say, her working memory or planning problem solving, could I adjust my prescription so that she doesn't have to plan a whole bunch and problem solving and deal with all of these issues, goal conflict, and make all these difficult decisions? Maybe I could work on a prescription that meets her where she is, meets her at her capacity, so that she could, again, hopefully connect the intention behavior gap. There's a lot to be said with this, and I just want to share one really, really neat study to show you the impact of the capacity. This is the medial prefrontal cortex of the brain, and it's been looked at. This study did a very neat analysis of smoking ads. So A, B, and C, these are 3 smoking ads, and over on the left, they actually asked the participants who watched these 30-second smoking ads or anti-smoking ads, how would you rate how effective that ad was? And so they did that. And they found that after the analysis that ad B was the best, based on, again, self-reported measures by the participants. Well, at the same time, as they watched these 3 ads, they were in a functional MRI machine, and the machine measured their medial prefrontal cortex activity. More activity is what they were looking at. So which one of these ads induced more activity, which again is related to executive function, thinking, cognition, planning, problem solving, etc.? Well, they found something different. They actually found that B was not the most effective in raising this activity. It was ad C. So this was really the neat part to me. They took all 3 of these ads, and they were actually national anti-smoking ad campaigns that each had its own separate 1-800 number. So then over the next period of time, they measured call volume. So the question was this: was it the self-reported effectiveness of the ad that would match the call volume, or would it be the subconscious activity of the brain, their executive levels or capacity, that would predict or relate to call volume? Well, that's what they found. So the subconscious brain, in its response to these anti-smoking ads, is what was more predictive of call volume than what people said. So it's not that we can't trust what people say, but there is this deeper underlying level of executive capacity that might be telling us more than what we know now. But again, where do we go with this? This is new, but I thought it'd be interesting for you to know as the research comes out, and especially how do we implement this in practice. I think the simple way is to sort of assess, and there are some paper pencil measures of executive function that we can get. But just talking to participants, see how good they are at self-control, how good are they at planning and problem solving. So we know it can impact behavior, but how do we increase the executive capacity? Now, it's not going to be easy. This study looked at participants, and they were only asked to sit in a room. Before they went into the room, they were asked to strap on this little contraption, and they were shocked They were asked how that felt. Nobody liked it. Will you take money to get shocked again? They said no. So they said, okay, they put them in a room all by themselves, but they kept the ability, if they wanted, they could shock themselves. 8, 16 minutes, something like that. Almost everybody shocked themselves. They would rather shock themselves than sit quietly with their own mind, the challenges of the disengaged mind. Patience, love, consideration for other, altruism, all these great concepts that we know and we've cherished for years. Now we're seeing them come through again in this idea of executive function, perhaps, cognitive capacity, when I have moments of difficulty, when I have moments of silence, when I need to be patient, when I need to delay gratification, do I have the capacity to do that? Okay, last but not least is the process. And I'm going to summarize this with a gear system that I use and I created to represent goals. The big gear I'm using as an example, health, is called a B goal, B-E. This is something that I want to be. It could be attractive. It could be a particular weight. But the idea is I want to be something. Well, in order for that gear to move, I have to do certain behaviors. So to be healthy, I need to do exercise, for example. But you notice I can't do exercise until I take small actions moment to moment, day to day. So for instance, I got to buy a gym membership. I have to get some shoes. I got to put on my shoes. I got to tie my shoes. I got to remember to go be active. I got to pack my bag. I got to do this. I got to do that. Too many times from the professional standpoint, from the practitioner, we focus on the B goals. I want you to be healthy, or the patient wants to be healthy. We focus on the do goals. Okay, we'll do this, 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 and this. But we don't focus on the action goals. And the reason I like this as a gear system is because the only way the health goal clicks, the B goal clicks, is if the do goal happens, the gear moves. If the do gear, the only way that works is if the action gear moves. So where should our focus be? Well, in practice, we should be focusing more on those small day-to-day, moment-to-moment. One of our main goals should be keeping that small gear spinning as much and as fast as possible and preventing delays, such as behaviors that people choose they think is going to reach them to health, or reach them to a more attractive body, or to get them more functional, but doesn't. So again, if that's what they believe, a part of our job is to make sure they're choosing the correct action and do goals. Or if there's conflicting anti-goals. You know, I want to go home and eat healthy tonight, but when I walk in and open my pantry to Willy Wonka's chocolate factory, I could have all these other options. And yeah, I want to eat healthy. I want to keep that action goal spinning. But you know what? I'd rather have this unhealthy option. Yeah, we can remove stuff from the house and try our best to remove goal conflict, but life is going to pose threats to our behavior. Can somebody override that? Are we helping our patients with tactics, with skills, with perceptions that can help them override conflicting goals? And of course, could be a whole nother 6 hours where we discuss all the barriers that could come in and impede this system, impede this gear system where people want to act, they intend to do it, but this, and this. For instance, time, cost, motivation are consistently the top 3 barriers to physical activity and healthy eating. Are we helping our patients move forward so that they can overcome these issues, keep the action goal spinning, so that eventually they can connect intention to behavior? So it might not be as easy as just doing it. But as I mentioned earlier, hopefully today you've learned some things about how we can be unsuccessful so that when you're helping patients in the future, you can show them ways and teach them ways to be successful. Thank you. You are welcome to emailing me if you have questions or concerns. Also, I have a blog called fitnesspudding.com, which covers common fitness and health myths. And if you'd love to check that out, I would love to discuss those with you. Thank you for attending, and I look forward to hearing from you in the future.